Primary investigation of any cardiovascular disease is ECG, electrocardiogram, that gives clue of different diseases in the cardiology like ischemic heart disease, myocardial infarction, any valvular heart disease, LVH, hypertension, hypertrophy. Then after, if we are suspecting ischemic heart disease, especially in ischemic heart disease, we have to go for in acute myocardial infarction or ischemic heart disease, echo, stress echo and coronary angiography. Cardiovascular diagnostic require a step by approach. So echo is structural and functional. Stress echo is uncover the ischemia and angiography defines the anatomy. So echocardiography, stress echo and coronary angiography pivotal roles in the diagnosis and management of cardiovascular disease. Echocardiography provide a non-invasive visualization, while CAG and stress echo by the use of the pharmacological maneuvers, it may be a invasive procedures. Go wait. Stress echocardiography reveals ischemia and myocardial viability by combining echo with exercise. So while we going the plain echo without any stress of pharmacological or exercise induced stress, it only gives a diagnostic of acute myocardial ischemia. It is a ischemic only. It doesn't give clue about the viability of myocardium. If patient, suppose patient comes to you after 14 days or 1 week or 1 month, patient have a ischemic pain and echo is suggestive of a necrosis. So we have to diagnose if there is a viability of a myocardium is persist or not. If viability of surrounding myocardium is there, then we can go for the PTC or CABG. To reveal this ischemia and myocardial viability, we have to go echo along with exercise and pharmacological intervention, that is known as stress echo. Coronary angiography remains the gold standard if we wants to find the anatomically distribution of ischemic part of the heart, whether it's right coronary artery affected or left coronary. So before going to intervention, CAG is important. So by this we can go for management of the acute myocardial infarction. So it is a gold standard for the diagnostic and therapeutic both. Together these tests offers a complementary structural, functional and anatomical information that are crucial in the modern cardiology. First, echo. Echocardiography is the indications of definite indications are some are indicated in the suspected or non-valvular heart disease for assessment of stenosis or valvular regurgitation heart wall defects like mitral stenosis, mitral regurgitation, aortic stenosis or aortic regurgitation. So echocardiography can detect any suspected valvular heart disease, whether it may be a stenotic heart valve disease or it may be a regurgitant lesion. Both can be detected by the echo. It is a standard test in patient with a heart failure to evaluate left ventricular functioning. So if we want to know the left ventricular functioning, if suspected case of the heart failure, so echo is the diagnostic choice. It goes with the systolic and diastolic functional assessment. Third one is a ischemic heart disease to detect regional wall motion abnormality. Sometimes patient comes to with chest pain in emergency, ECG is normal. While you are suspecting strong suspicion of ischemia, then we can go for ischemic heart disease to diagnose echo. Echo suggests that patient have a regional wall motion abnormality it may have associated with the normal ECG also. Then we have to proceed for the management of ischemic heart disease. So echo is the earliest diagnostic for the any ischemic heart disease, whether ECG may be normal, but sometimes ECG is normal, echo is normal. Then we have to go for CAG, coronary angiography. Pericardial disease, fourth one is pericardial disease such as pericardial effusion or pericardial tamponade or constrictive pericarditis are the assessed by the echo. It shows the collection of the fluid is increased in the pericardium cavity. So it is valuable in the congenital heart disease, pulmonary hypertension, infective endocarditis. It shows vegetation also. It is useful in the infective endocarditis also. In cardiomyopathy, obviously there is a left ventricular systolic function is assessed by the echo. So cardiomyopathy, heart failure, pulmonary hypertension, congenital heart disease, valvular heart disease, all these can be assessed by the echo, and we can monitor with the echo, and therapeutic intervention can be carried out with the help of echo. Finding that suggests some particular disease in the echo. So echo demonstrates valvular stenosis as a restricted leaflet mobility. It depends on the type of valve affected. Like mitral valve, there is a mitral leaflets are restricted mobility during the flow. If we see the in color 2D echo along with the color Doppler, so that shows that there is a restriction of the fluid during stenosis, or there may be regurgitant or the backflow of the blood if there is a regurgitant lesion in the valve. It quantified systolic function using ejection fraction, fractional shortening, diastolic dysfunctions through the transmitral flow pattern. Flow from the left atria to left ventricle gives many of disease clue, like it ejection fraction can be estimated by this, fractional shortening can be estimated, or there is sometimes there is a early diastolic dysfunction that can be also detected by the echo. So echo these suggests these finding in the different disease. Obviously in the ischemic heart disease there is a wall motion abnormality. It depends on the anterior wall, lateral wall, posterior wall, inferior wall. So particular infarction have a particular abnormality in the motion wall. So wall motion get decreased, reduced, or sometimes absent. That is known as akinesia, otherwise it is known as dyskinesia or hypokinesia. So it is a wall abnormality that indicate patient have ischemia or infarction. In the pericardial effusion that appears as the echo-free space or tamponade is assessed by the right atrial or ventricular collapse. There is a collection of the fluid that indicates that the echo-free space, along with this there is a, if there is right atrium or right ventricular, there is a collapse, there is a less mobility during systole in the right atria, right ventricle, along with the echo-free space, strong suggestion of the pericardial effusion. Sometimes there is a thickening of the pericardium that is known as constrictive pericarditis due to the serosanguineous fluid, or there may be exogenous fluid with the infection. There may be restriction, constriction, pericarditis. Sometimes there is a congenital heart disease, so shunt may be detected by the echo. Right to left or left to right shunt can be detected. Masses such as thrombus, myxomas, tumor, elevated pulmonary pressure, all these can be additionally can be found in different disease. In the infective endocarditis, there is a vegetation along the wall or the valve. Stress echo, as the name suggests, stress. When patient is in a stress by the use of some pharmacological or by the exercise, at that time echo is done, and that echo will more suggestive of the different diseases. So stress echo is indicated for diagnosing coronary artery disease in the intermediate pre-test probability. So viability should be checked before going to the angioplasty or stenting, sometimes we need stress echo. It helps in risk stratification of the non-coronary artery disease and decision making for revascularization also. It is used when resting ECG and interpretable for exercise testing such as left bundle branch block or LBH. So sometimes patient in ECG is suggestive of LBB, left bundle branch block. A left bundle branch block may be a indication of ischemic heart disease. At that time, to detect the ischemia, we have to go for a stress echo. Otherwise, it's the first time presentation of LBB is considered as a ischemic heart disease also, or acute MI, myocardial infarction. So, it's used when resting ECG and interpretable for exercise testing is done. Dobutamine is a drug that tests the echo, evaluate the myocardial viability in ischemic myocardiopathy. It is used for pre-operative cardiac risk assessment also. If patient is already in cardiac compromised, in that state, a patient is ejection fraction is 60% in the normal state or resting state, but patient is a non-case of coronary cardiac disease. So to see some before going to the major operative procedure, sometime we need the stress echo. In the valvular heart disease, it assesses the transmitral gradient and contractile reserve in the aortic stenosis. So aortic stenosis stress echo is important because aortic stenosis before going to operate this patient, because it have association with the coronary artery disease sometime also. So in the patient of aortic stenosis, if going to the operate or replacement of the valve, before going that we have to go for the stress echo to assess the ejection fraction and the valve abnormalities like ischemia. Finding new or worsening regional wall motion abnormalities during stress indicate reversible ischemia. So it may indicate that there is some part of the viable myocardium that can be saved by the procedure like stenting, or there is CABG. Fixed wall motion abnormality present both at rest and stress suggests prior infarction. If there is a fixed motion abnormality, that indicates the patient doesn't have a viable myocardium. So there is no role of the procedure. That indicates prior infarction, no new infarction. Normal stress echo exclude a significant CAD and indicate excellent prognosis. Global LV dysfunction during stress suggests severe multivessels or left main disease. In mitral stenosis, stress echo reveals increased transmitral gradient and pulmonary pressure increased. So there are some findings we can detect by the stress echo, and accordingly we can manage patient for the cardiac diseases. In the clinically used to diagnose the CAD when clinical suspicion is moderate to severe. Strong suspicion of coronary artery disease not detected by the ECG and echo, then we can plan for stress echo before going to CAG. Coronary angiography, it stratified risk stratification in patient post MI or with stable angina. It adds surgical planning by the clarifying the myocardial viability before going any operative procedure. In valvular disease, it detects latent hemodynamic compromise not evident even at rest. At rest, hemodynamically patient is stable. If we go for a stress echo, then we have to go for the stress echo for the valvular hemodynamically instability. It is useful in preoperative screening for patient undergoing high-risk surgeries. It is particularly helpful when nuclear perfusion imaging is not available. But nowadays, nuclear perfusion is available most of the centers. So stress echo have lesser importance than the nuclear perfusion scan. Coronary angiography is the last one. Is indicated in acute coronary syndromes like STEMI for primary PCI and high risk non-STEMI or unstable angina. Patient have unstable angina, non-ST elevation MI or primary PCI. So coronary angiography is indicated for the acute coronary syndromes. While in the stable angina, it is done when symptoms are refractory to medical therapy or when stress testing suggests high risk. So one is a acute coronary syndrome or acute myocardial infarction. Patient have a acute myocardial infarction, so we have to plan for primary PCI. In that case, coronary angiography is must. Second one is a patient who have a high risk for the non-ST elevation MI or unstable, because patient have a frequent admission in hospital due to the chest pain, or even in rest patient having a chest pain and enzymes levels are high. So in these conditions, there is a strong suspicion of coronary stenosis. In that case, coronary angiography is indicated. In the stable angina, patient have a chest pain only on exertion, not in rest. That is comes in under category of the stable angina. In that conditions, when symptoms are refractory to medical therapy, or sometimes stress echo is suggestive positive in the patient of a stable angina and refractory to medical therapy. Medical management is optimized by the antiplatelet and vasodilators and the nitroglycerins, some anti morphine drugs or opioid, but patient have a recurrent chest pain not relieved by the standard therapy, then we have to go for the coronary angiography performed before valvular surgery in the older patient, especially in the aortic valve lesion. Patient have a aortic valve, either stenosis or regurgitant lesion. Before going to operate these patient of the valvular heart disease, we have to go for the coronary angiography, because these most of the time have a of ischemia along with this aortic disease. Survivor of sudden cardiac arrest, definitely there is a chances of coronary artery stenosis is higher. In these patients also coronary angiography is indicated. So sudden cardiac arrest, patient have a STEMI, non-ST elevation MI, ST elevation MI, unstable angina, stable angina. Before going to operate for the valvular heart disease, especially for the aortic valve disease, or there is sudden cardiac arrest, all these conditions have a coronary angiography should be done. Finding, as the age process, it is a aging process, there is atherosclerosis in the coronary arteries along with all the vessels in the body. So likewise in the coronary arteries there is a atherosclerosis. As the age advance, there is a atherosclerosis. No one is there that doesn't have atherosclerosis in the coronary artery, or there is a plaque formation, or there is stenosis. But there is a definite criteria. Single vessel disease involve more than 70% stenosis in burn artery. Double artery or triple vessel disease involve more. Left main coronary artery disease is more than 50% stenosis, carries a worse prognosis, or these have required for the coronary angiography and stenting. If there is a 2 or 3 vessels are involved, right coronary or other coronary, oblique coronary artery, other 2 or 3 vessels involved, there is a surgery is a choice, CABG, bypass grafting. But a single vessel disease, usually we plan for stenting. But left main coronary artery more than 50%. If some patient have a 60% involvement or the stenosis or block of the coronary artery of the left main coronary artery, definitely the stenting is the drug of plan of choice. While in other coronary arteries, more than 70% stenosis should be there before going to stenting. So acute MI is visualized as a thrombus or total occlusion. Diffuse atherosclerosis and focal lesion can be delineated. Other findings include is like a stent re-stenose, already stent have stenose, graft occlusion. If there is a CABG, that can be occluded in the further years. Collateral circulation is formed. Anomalous coronary origins of the arteries that can be detected by the coronary angiography. So stenosis of the coronary artery can be detected by the coronary angiography. Along with this, if there is a collateral formed, at that condition we can deline for the stenting or CABG if there already collateral circulation is formed. Third one, graft that is already done can be occluded, can be detected by the CAG. Patient comes to you with a chest pain again after CABG. 2 years back, the patient have a history of the graft. So definitely there is suspicion of the occlusion. Prior patient have a stent. After 5 years or 10 years, they can definitely stenose. So the restenosis may be seen in this patient. Anomalous coronary origin may be detected by the angiography. So coronary angiography guide PCI or stenting and procedure or surgical procedure like CABG, a decision by the localizing or quantifying the stenosis, how much it extends, stenosed, and where is it stenosed. Both can be detected by coronary angiography to guide the CABG or PCI. It identified the culprit lesion in the acute coronary syndrome and immediate intervention may be required. It helps to exclude the CAD in patient with unexplained cardiomyopathy also. It provides anatomical mapping and congenital anomalies also. It is used in follow-up patient detect the stenosis or the graft failure or graft occlusion. It remains the definitive diagnostic and therapeutic modality despite invasive nature. There is no comparison, but there is somehow we can some point we can discuss in the comparison modality. Echocardiography is a non-invasive, so it is a better choice. Evaluate the structural and somewhere functional also. Hemodynamically stability or instability can be detected by the echo. Stress echo is a non-invasive also. Functional test that unmask the ischemia and assess the viability of the myocardium. Coronary angiography have a negative value because it has an invasive procedure and anatomically gold standard for the coronary artery evaluation, and echo detect murmur, cardiomyopathy, effusion along with this ischemia. Stress echo clarified the CAD and valve severity, that better choice for stress echo to clarify severity of valve, because hemodynamically and the pressure gradient can be detected by the stress echo. Angiography is reserved for the revascularization planning. Each test answers a different clinical way, so there is a different modality have a different superiority. So we cannot say the echocardiography is lesser importance than the stress echo or angiography. So equally have important along with as we have disease accordingly. So in summary, echocardiography, stress echo and coronary angiography are complementary modality to each other rather than single. Echo provides structural and functional assessment, then stress echo add the ischemia viability information, and coronary angiography exactly define the coronary anatomy and essential for intervention planning. So investigation depends on the clinical scenario, risk, age, and management goal. Together they form the backbone of modern cardiovascular diagnostic and management. So mastery of their indication finding is essential for the safe and effective management of patient.